Dear President, dear colleagues, I want to thank one more time the organizers, Dr. Patakos, Professor Sparias, for this kind invitation. And in the next 5 to 10 minutes, I'm going to present the data regarding the PVL defects in mitral position. So, opposed to defects in aortic position, the mitral valve PVLs are more common, more symptomatic, they are larger, and often repair is more complex. In most of the cases, these defects are located between the anterior lateral and posterior medial aspects of the mitral ring, and in most of the cases, up to 80 to 85%, they are oval or crescent in shape, having irregular borders. As far as pathophysiology is concerned, there are several factors favoring the development of these defects, such as the existence of significant annular calcification, the existence of connective tissue disorders, the chronic treatment with corticosteroids, and of course there are several technical considerations as well. In most of the cases occur relatively early, up to 75% in the first year post-operation, and the rest 25 may occur later after the year post-operation. However, we have always to keep in mind that infectious endocarditis could be a cause of such defects. Clinically, in most of the cases, they are asymptomatic, having a benign clinical course. However, up to 5% of the cases may lead to severe clinical consequences, such as congestive heart failure due to volume overload, when we have large leaks and large defects, symptomatic hemolysis that may often occur with smaller leaks, and of course, infectious endocarditis up to 8% of the cases. This is a very interesting slide coming from Garcia, showing the different hemodynamic patterns that PVLs combined with hemolysis, and just to mention fragmentation, collision, and acceleration. Repair is the gold standard treatment approach when we have symptomatic such defects, and although surgery is the gold standard, there is often associated with significant morbidity and mortality, and up to 30% of the cases may not be very successful in terms of recurrency. Very recently, data coming from the Mayo Clinic showed that the transcutaneous approach could be a very good alternative to surgical approach in high surgical risk cases, having very good long-term results. And this is data coming from the KISS registry revealing that the transcutaneous approach is characterized by low in-hospital and shorter-term complications and mortality versus the surgery, which is characterized by better long-term results, but however it's associated with high perioperative mortality. This is a very interesting meta-analysis with almost 2,000 cases, revealing that the transcutaneous approach is associated with lower perioperative mortality. However, we can see often moderate to severe PVL thereafter, and of course, sometimes we see also congestive heart failure symptomatology. All this data reflected by the latest guidelines from both parts of the Atlantic Ocean, suggesting and recommending transcutaneous approach as class 2A indication when there is a prohibitive surgical risk, when there is done in centers of excellence, and when there are favorable anatomical features, such as having a sufficient distance from the Sewing ring, when there are smaller in size, when there are single and short tunnels. However, limitations for the transcutaneous approach exist, and just to mention the instability of the mechanical valve or the prosthetic valve, the existence of active endocarditis, the need for another cardiac surgery, and of course, the presence of thrombus. Imaging plays a crucial role in order to define the severity, in order to define the anatomy of these defects, especially at the place of the mitral position. The toe is of paramount importance. And when more information are needed, especially at the place of the aortic valves, we can proceed with CT analysis, with 3D and 4D reconstruction, which can give us insight information about the location, the size, and also we can take information regarding the optimal crossing view angle. Imaging is also important during the procedure in order to evaluate the correct position and device and to confirm that there was no any disturbance of the existing valve, and also to estimate if there is any residual PVL. And here is just an example of a narrow projection showing the same ring on its side and how you can appreciate the release of a such device. Fusion techniques can also be used. They can give us inside dynamic information during the procedure, reducing the time needed. And as far as the crossing and the approach, we can appreciate that there is most commonly used the antegrade approach through the femoral vein, through the septum, the transeptal by transeptal puncturing, where we use and follow the guides as the TEER procedures. And in such cases, we have to go as posterior and as superior as possible in order to have appropriate space inside the left atrium. Retrograde transapical approach could be another option, especially in posterior and septal located defects. However, there is a surgical approach and therefore requires, it's characterized by higher degree of perioperative complications. When further support is needed, we can use the different loop techniques. And as far as the device we choose, there are several not at the moment dedicated devices, such as the vascular plaque 1, the vascular plaque 2, the vascular plaque 3, which is oval in shape. It is most commonly used in oval and crescent-shaped PVLs, most commonly used in Europe. There is no at the moment FDA approved by the USA. Also the AVP4, which are small and are very suitable for small oblique PVLs. And just to mention the atrial septal defect occluder device, the ventricular septal defect occluder device, which however they are stiffer and some very often they are correlated with hemolysis. The only at the moment dedicated device is the Occlutech. It has CE mark since 2014. It's made from nitinol. It comes in 2 different geometries. It has secure mechanisms and they are available in different sizes. So when we have large defects, oval or crescent in shape, which are very often very complex, the possibility of using more than one devices simultaneously or in a sequential deployment way could be a very good option. This is a nice also technique described by Emory 1 year ago, showing that the sequential deployment of a covered stent and thereafter a vascular plaque could be a very good option, and the recently published data revealed 100% procedural success. There is no complications, and there is no significant, with a significant reduction of PVL. When resistance occurs, in order to pass through these defects and leaks, we may use stiffer wires. You can use smaller hydrophilic catheters. You can choose a different point of access, and of course, you can use the so-called inflated Swan-Cansin law to advance the shield. And of course, you can use also the different loop techniques. Of course, during the procedure, we have to avoid complications having to do with the access site, and of course, complications having to do with the release of the device in order to avoid the interference with the prosthetic valve that may obstruct the mechanical order by prosthetic valve, and of course, you have to avoid the embolization of the device. Another complication that can be seen when we have not totally occlusion of such defects is the hemolytic anemia, and it is more often seen in mitral position when there is severe calcification of the annulus. And in such cases, we have either to repeat the transcutaneous approach, to go for the surgery, or to wait, hoping that the epithelialization and the fibrosis that is going to be developed in the next couple, 3 months is going to diminish such defects. The initial experience for PVL occlusion came and publicated in 1992 by a small series of 8 cases in the aortic position coming from Hurahan, and 10 years later we have the first publication for the defects in place of mitral position. And we can see, based on recently meta-analysis that the technical and procedural success rates seems to be higher in place of the aortic defects versus mitral defects. This is a publication come 2 years ago. This is the Greek experience of almost 30 cases in the place of the mitral defect, where you can appreciate that the AVP3 was the most commonly used occluder device, and of course the transseptal approach was the most commonly used approach. Data coming from the Occlutech shows that the device success, the procedural success, and the clinical success goes up to 90% of the cases. And the data coming from the Spain reveal that an independent predictor for a success in such cases is the type of the device used, which most commonly is the AVP3, and of course, the experience of the center. So this is a very nice treatment algorithm that we have always to keep in mind when we have a symptomatic mitral PVL, which there is no active endocarditis, when there is no instability of the existing valve, then we can think about the transcutaneous approach. And in summary, just to mention that the PVL defects are relatively rare. The procedure can be challenging, but the success rate in centers of excellence can go up to 90%. Imaging is of meticulous importance, and of course it is very important to resolve completely such defects in order to avoid hemolysis thereafter. And with that, I want to thank you for your attention.
Thank you very much, Dr. Chalapas. We heard the transcatheter approach. Let's go to the next speaker, Dr. Panagiotou.